So my name is Dr. Mohammad Kashif Shazli. I am chairing the Department of Radiology. There is a big hospital setup of its own kind that is total free of cost for everyone, and it has 14 branches across the country of Pakistan, and all tertiary care services are free of cost there. Before this hospital, I was directing the radiology department of Ziauddin University Hospital. That is a tertiary care department, a tertiary care hospital, and a big radiology department. Nowadays, I am also General Secretary of Interventional Radiology Society of Pakistan. So there is no obvious disclaimer, no conflict of interest. So in our department, we offer these procedures very frequently uh, under city guidance or even ultrasound guidance, and there are some limitations of city guidance as well as ultrasound guidance guided procedures. We do bone biopsies, intra-articular injections and arthrograms, and city guided radiofrequency or microwave ablation therapies in our department. I was doing ablation therapy of bone since 2014. So, okay. Let me choose the marker. So, about ablation therapies, these are very simpler procedure relative in comparison to the surgery. Surgical management is more complicated, can take more time of the patient, can be more cost consuming. Uh, Ablation therapies are less traumatic as well, and these are done for curative intentions. The recovery is very quick. Most of the time, the lesions having less than 2 centimeter diameter can radically be treated with RFA or microwave ablation. These therapies can be repeated for recurrence or multiple lesions at the same time. Uh, these ablation therapies cause necrosis and stimulate anti-tumor immune response system that suppresses the tumor growth in the body. So these are some characteristic features of the thermal ablation and very basic information. These are available thermal ablation therapies worldwide. In our country, we do only radiofrequency ablation and microwave ablation. We don't have, as far as our departments are concerned and our cities are concerned, I know that there is no availability of cryoablation or high intensity focused ultrasound ablations. So some basic information regarding microwave ablation mechanism of treatment. The tumor tissue is more sensitive to heat because it is rich in water and has low pH. Microwave antenna is inserted into the tumor tissue. High frequency microwave radiation causes molecular agitation at higher speed, produces heat between 65 degrees centigrade till 100 degrees centigrade, resulting in coagulation necrosis. This occurs in a very short period of time as compared to radiofrequency ablation therapy. Simultaneously, the surrounding normal tissue is protected from the damage. The only microwave system available in Pakistan is Ecomedical, and we used to do liver ablations, bone ablation, breast lesions, and fibroids. There are few cases of fibroid ablation done at our center as well. This is the basic chart that demonstrates the delivery of the energy in a certain period of time. And for different size of lesions, there are different recommendations according to the provided charts. All we need is one imaging modality, whether ultrasound, CT scan, and rarely MRI. Most of the time we do, not most of the time, all the time we do ablation of osteoid osteoma under city guidance. Plus generator, we require generator and microwave ablation antenna. Some basic information regarding radiofrequency ablation. The application of radiofrequency energy and its thermal effect on the tissue were described as early as 1891 by D. Orson Welles, when RF waves that passed through tissue were observed to cause an increase in local tissue temperature. The RF probe acts as the cathode of an electrical circuit that is closed by the application of dispersing pads on the patient's thigh. Because of the small cross-sectional area of the probe tip, there is a very high energy flux around it. On the other hand, the large cross-sectional area of the grounding pads disperses the energy, minimizing the energy flux. As a result, tissue damage is limited to the part of the circuit that surrounds the probe of the tip of the probe. The radio frequency, one of the radio frequency generator we use that is available in Pakistan is RF 3000 generator of Boston Scientific. We use soloist needle for bone ablation of osteoid osteomas, and it is of 18 and 16 gauge. So before we start the procedure, we evaluate the patient, we take the history, we do physical examination. The most common lesion we ablate is osteoid osteoma, and the osteoid osteoma has very classical clinical history of night pain that is relieved with some NSAIDs, likely aspirin, etc. We evaluate the imaging, especially we want to see CT scan or MRI if available. Coagulation profile of the patient should be within normal limits. We also see some tumor markers if we are going to ablate some focal solitary bony metastasis. On the day of procedure, we again examine and localize the lesion. We take verbal and written consents, and whatever needed for procedure. We do all procedures under general anesthesia. Proper positioning is very important for needle incision, and especially we require orthopedic drill for bone digging and to reach the lesion, because as we know that the surrounding bone the surrounding bone is very thick and laminated, and it is very difficult to approach through Jamshedi or some biopsy needle. So few years back we started doing this procedure with orthopedic drill that is more easier and convenient and accurate. And then we plan for ablation. So here are some CT guided tumor ablations. These two cases are we done with the microwave ablation, the eco medical system, and you can see here the needle, the lesion that has a very circumscribed hypodense nidus and surrounding thick cortex. This thick cortex is very difficult to pierce, and that's why we recommend and we suggest to have an orthopedic drill to reach and take this area. So because the microwave needle that has been provided to us has 11 gauge, that is very thick needle, so we require a big bore to introduce the needle and place the needle within the nidus. The tip of the microwave needle is out of circuit, and it is not the area where burning or ablation is being done. So these are the two markers, the three markers, all are black on CT scan, and you can see the distal marker, middle marker, and the proximal marker. And the middle marker is the area where the maximum intensity of the energy is being delivered to the bone. So we have to place this middle dot within the nidus. And then microwave, as we all know, is very quick, and it takes a few minutes to say a few seconds to a few minutes for ablation. And when the time is over, we put out the needle from the bone. And this case was a challenging one because of the position of the lesion that was in the neck of the femur, and it was also very deep. So for the accuracy, we use orthopedic drill and place very accurately the microwave needle. But you can see here that to reach this area in the mid of the approximately mid of the femoral neck, we have to dig the whole neck of the femur bone. That is of area of concern, and this was the only patient where after 3 months the patient had fracture of the neck of the femur, and on follow-up CT scan there was bone infarct. So this is an area of concern we will discuss later with our experts as well. So here a few cases from radiofrequency ablation. We use radiofrequency ablation in most of superficial lesions. Like here you can see a very superficial lesion in the anterior cortex of the right femur. And considering the superficiality of the lesion, we use radiofrequency rather microwave ablation. And if we could use microwave ablation. Okay, so these are some few cases of radiofrequency ablation. So as I told, the technique is simple but very critical to place the tip of the, if we are offering RFA radiofrequency ablation, we have to place the tip of the needle within the center of the nidus. And if we are doing ablation therapy with microwave, the central dot of the distal tip of the microwave ablation antenna must be placed within the nidus. So there are some technical points, important points to be considered whenever we are offering RFA or microwave. The needle direction is of utmost importance, and some orthopedic or our colleagues, other IR colleagues use fluoroscopic guidance, but I recommend and strongly suggest to do all these cases under CT guidance. Simultaneous biopsy of the core is recommended for definite 100% diagnosis. Sometimes it is very challenging to get tissue for histopathology because of the size of the lesion and the pore of the approaching needle. So sometimes it is impossible or difficult, but many times we can get some tissue for histopathology. Most importantly, the neurovascular bundle should have a gap of at least 2 centimeters away from the thermal zone. This is very important, and that is why imaging, the prior imaging and planning is very important before ablation. For deep lesions and spine lesions are dedicated orthopedic drill is advised in experienced hand. So make a team for bone ablation. These are some important points to be considered. As far as literature is concerned, very few scientific research articles are available which are really comparing big data of RFA versus microwave ablation of bones. I will show a couple of papers, but in our experience of 8 to 9 years, reminding me that we did all cases of osteoid osteoma with radiofrequency ablation before 2017, and we didn't have access or availability of microwave ablation antenna. Then in 2007, late 2017, microwave ablation arrived in Pakistan for bone ablation therapies, and we adopted this technique. And since then, we are doing RFA and microwave both. So in comparison, in our experience, that is a loco-regional experience in sense, and we are going to publish when we will get some good number of cases, at least 50 cases. Till now, we have done less than 30 cases. I will show. So if we compare RFA with microwave, the size or the gauge and size of the needle really matters. If we see the RFA needle, it is of 16 gauge versus a thick needle of 11 gauge, which is being used in microwave. So there is a big difference between the gauge, and if the gauge of the ablation needle is thick, then there are certain increased chances of bone break, uh, and we cannot offer microwave in thin bones like fibula or transverse process of any vertebra. So the size of the gauge and size of needle really matters in some cases. The energy delivery in RFA is very circumscribed and round in shape, and it ablates 1.2 to 1.3 centimeter diameter of the bone, whereas the ablation is elliptical in microwave ablation, and we think we don't 100% know, but we think the energy delivery is relatively sometimes uncontrolled in microwave ablation. Uh, Technically, RFA is more challenging because placing the tip of the needle within the nidus is sometimes very difficult, because many times the nidus is so small, less than 1 centimeter, that the tip touches the bone. And whenever in RFA tip of the needle touches the bone, the whole electrical circle deteriorates, and the ablation is stopped. So it is rarely seen in microwave ablation, where just we have to place the needle adequately and it's done. So technically, microwave ablation is relatively easier to do, relatively less time consuming than RFA. In RFA, we have an indicator of completion of the therapy, that is impedance, whereas in microwave, we don't have any indicator except the timer. When the time is over, we consider it that it is done. Uh, RFA requires less bone drilling, as I said, whereas due to thick gauge of the needle, microwave ablation technique require a thick drilling of the bone. RF in Pakistan, in our setup, RF is more expensive, and microwave ablation is relatively less expensive and cheaper. Both are available, however. So, in our experience, we think that RFA may be more optimal and adequate for superficial lesions, or the lesions which are occurring in thin bones, whereas microwave ablation may be more appropriate for thick bones and deeper lesions. So here you can see the post ablation zone, post ablation zone of the area where we drill the bone. So it is relatively thicker than RFA. So this is the only paper available in Pakistan, and it was from Aga Khan University Hospital, and they concluded that the image guided percutaneous radiofrequency ablation is minimally invasive and safe treatment option with high efficacy and high rate of technical success for the treatment of osteoid osteoma. The risk of recurrence is remote, with all patients achieving independent recovery. This recently published paper in 2019 compared the efficacy of microwave and radiofrequency ablation, and they concluded that in our study, the short-term efficacy of microwave ablation was considerably favorable, with a relatively low rate of complication. Uh, our results also showed that microwave ablation was effective for pain relief and improves patient quality of life, making it a feasible treatment alternative for bone tumor. So there are not so much studies available with large clinical data to compare both of these techniques, but I think both of these have their indications. Both are very effective. Technical success rate are almost 100% in both techniques. But in our setup, our local regional experience, we got some complications with microwave ablation technique rather with RFA. but it will require further evaluation and assessment in future with a big number of cases. So take-home message is very clear that ablation therapies are accurate, more precise, more tolerable, and minimally invasive techniques for bone tumor with minimal risk of recurrence and less hospital stay. Thank you very much. Over to
thank you so much, Dr. Kashif. That was an excellent presentation. Really enjoyed it. I think it is early days in bone ablation in Pakistan, and probably you're leading the charge. So, so well done. We do osteoma ablations with soloist Boston RFA system. Usually we're not using microwave at the moment. I think most of my colleagues will probably be the same sort of boat. But we really enjoyed that talk. It was very good. There's obviously a lot of a big role for bone ablation and bone medicine with augmentation, consolidation, things like that as well. But first of all, I think I'll ask Dana to if there's any questions that have been asked on the messaging system.
Yes, here's a question about osteoid osteoma. Do you do microablation for osteoid osteoma? And if you do, what is the ablation protocol? And do you also do track ablation?
No. Okay. I have already discussed the technique of ablation. As far as the track ablation is concerned, as the osteoid osteoma is not a malignant lesion, so we don't need to ablate the track. And if we try to ablate the track, it will further cause the necrosis of the bone, and it will hurt the patient in future. Probably patient may get fracture of the bone. So we don't offer any track ablation.
Okay, what would be the recommended ablation output power and the time?
Recommended, it all depends on the size of the lesion and the area we want to ablate, and there are recommended charts every time available. We never remember these charts. We always refer to the recommended charts which are available. Whether we are doing RFA or microwave, we always refer to the available charts. That is our fixed protocol.
Do you have any questions from your end, Dr. Anwar?
It was a great talk. Just a few questions. The antenna is a bit bigger than the RFA antenna. Does that cause any problems with getting a biopsy initially?
I think there should not be any. I don't think there is any difference between the approach. When we approach the lesion, we drill the lesion, and we use orthopedic drill. So there is no difference between RFA or microwave, but we use a bigger driller in microwave than RFA. And even sometime in RFA, we use Jamshedi needle or biopsy needle simple, because we adopt that for superficial lesion, we should not offer microwave, because we have to dig the bone deep inside to place the needle, to place the central dot of the microwave ablation antenna inside the nidus. So for superficial lesion, definitely it is easier to get tissue biopsy. For deep lesions, sometimes due to big bore of the drill, we lost the tissue. So sometimes we are unable to get that adequate tissue for histopathology.
I think it's a really good idea that you're using a drill. We still use our shoulders and a needle, which can be quite painful.
Painful, yeah.
But yeah, that's great. Have you ever had any issues with a lesion that's in a place where it's weight bearing and you might need augmentation or fixation screws, cannulation screws, or something like that after the operation?
In our experience, only one patient got fracture of the neck of femur, and it was operated later. So I think at that time we will never, honestly speaking, we never considered that we are doing with microwave ablation and the ablation zone reaching up to 1.6 centimeter. And when we did our first case of microwave ablation, in fact, we took a piece of meat and we saw the area of ablation that is being offered by the distal tip. So it was reaching up to 1.5 to 1.6 centimeter, in fact. So really, honestly speaking, in that case of femur fracture, we didn't consider this, and the patient got fractured later after 3 months. So I think in some areas where there are critical weight bearing zones, we must consider uh, the size of the needle, the area of ablation, and different other some. And I think MDT approach is must for every case. We must also
Just one
consider the
last
opinion of
question.
opinion.
Just one last question, as we need to have the next talk as well. But we're both practicing in Pakistan. You said that the cost of microwave is less than the cost of RFA. That's interesting because that wasn't true.
Yeah. It's almost. I think microwave is 2/3 of that of RFA.
I
Means
see.
75 and 100. So this is
Right.
the difference.
Because cost issues are a big deal.
Big deal.
In our part of the world. That's great. So next we'll go to Zahid's talk. I think it's long awaited. Thermal ablation of lung lesions from simple to complex. So without further ado, we'll go back to Zahid. Thank you so much, Dr. Kashif.